Bernie's talk, again, back to routine stuff in the cath lab that we always have. I'm going to show you CTOs, two CTOs in a given case and how you address them slightly differently. So this is all around technicality of the CTOs. So here we have LCX CTO, and generally I like to believe that the first wire that you take should be your winning wire. And you have to plan the procedure. So every step that you plan has to have a meaning. So here is what we have done is we have taken a long sheet. You can see the long sheet on that side of the screen. This actually gives a lot of support. So this was elderly gentleman. So through the aorta, long sheet helps you to stabilize. Then we have used Ampla's guide catheter. And that again sort of looks straight into the circumflex. So another point which helps you to make a success. As you saw in the previous one, the Fielder XT could not cross. So we changed to Gaia 2. Can you put it in a loop? And this is a Gaia 2 making progress into the distality. So once you're reasonably sure the things are pretty easy, you advance the microcatheter. In this particular case, the microcatheter was able to go distally. You change to a BMW, you do some balloon, and this is the kind of result that you have post-balloon, and then you put stent. See how easily the stent tracks. My own feeling is you can see the long sheath in the descending aorta, and then you have an Ampla's catheter which is actually looking straight into the vessel. So both these make a strong point for everything to go in more easily. There's a very good support. Can you run the movie? And then this is the final result on this case. So in this particular case, we have used a microcatheter. We tried with Fielder XT and then moved to the Gaia. Same case, had a lesion in the LAD. I went for an FFR, which was 0.75. So this was an easy stent to the LAD. My own feeling in this particular case was this gentleman also had a total occlusion of the right, which was heavily collateralized from the left. So if he had failed on the right, it was quite important to have the flows in the LAD going, and this was probably another reason why we went for the LAD stenting. So then we come to the right. This was all done in the same sitting, and you can see right is sort of total occlusion, some collaterals at the site of the total occlusion, a very faint opacification of the distal vessel, which can be seen, giving you a hint that it's a very big size circulation. Also, there were good-sized collaterals coming from the opposite side. So addressing right is again going to be important. Again, choice of guide catheter, probably a right Ampla's would have been better. As the subsequent sequences show, the JR was offering very poor support. And this is the collaterals from right itself and good collaterals from the left system. You can see here lots of collaterals coming from the left side and opacifying a very dominant right circulation. The ventricular function showed inferior wall sort of hypokinesia, but overall contractility was around 45 to 50%. So we start this case with a microcatheter and a Fielder XT. This actually, on the left of the screen, you don't see it cross easily, but as you keep watching on the left of the screen, your right, you can see the Fielder XT did make an advance. So we thought we were in good position. And here, after Fielder XT had crossed, the new problem faced. Whatever balloon we got in, the balloon could not go across the lesion. So what are the issues when you have a balloon not going and your wire has crossed the CTO? So here we actually downsized the balloon from 1.5 to 1.25 and subsequently 1.0. You increase the support. In this particular case, there was no such chance, but we're already with a 7F guide catheter. 7 gives more support compared to 6. We could have used an AR compared to JR that we are working with. We had a long sheet in. Then you do a deep guide catheter and see if it supports and pushes the balloon. If this doesn't happen, you can use mother and child technique, and most of us would switch to a guide liner. We had a 7 French catheter, and I think this is the advantage. When you have a CTO, generally my choice would be to go with a bigger lumen catheter because you can take many devices. Like if you were to take an anchor balloon, as you can see here, that was another thing. You could have anchored the guide catheter with a balloon inflated in one of the side branches. So many times microcatheter doesn't go, balloon doesn't go, but an Corsair can go across, and Tornus could be another option which you can go and then come back to balloon and so on. And in the last resort, we can switch to rotablator if your balloon is not going. In our case, we tried some of these options and finally were successful with the rotablator. So you can see here the 1.25 balloon was not crossing, downsized to 1.0, not crossing. Here we bring in a guide liner, and guide liner you can see just outside the tip of the guide catheter. So it's about 10 to 15 millimeter outside the guide catheter. And as we are trying to push, whole thing collapses. So I think you also need to sort of keep watching what is happening. So we had to redo everything. Fortunately, we were able to get the wire down. Can you run this? And this is actually the way we bring in a guide liner. Can you freeze that? Whenever you want to bring in a guide liner, this is some other case, but you inflate the balloon into the distal portion. It gives support, and over that you bring in the guide liner, and this is the way we normally do. In this particular case, there was no such option, so we had to accept whatever guide liner was doing, and it was not enough. So we bring in a Corsair. Compared to microcatheter, you know the Corsair can be sort of twisted and pushed simultaneously, and this might help you to go across. So Corsair again fails. And then we decide to leave the Corsair there, and through the Corsair, we have passed the rotawire. So you allow the Corsair to go as far as possible, remove the wire which had crossed the CTO, and push a rotawire. Rotawire would generally go because it's a far thinner wire compared to the conventional 014 wire that we do. And this is the anchor technique that I talked to you. We didn't attempt in this particular case, but this is how you do it. Pick up a side branch, park your balloon, inflate the balloon, and this would offer a huge support for the guide catheter to stay at the ostium or maybe go a little bit deeper and thus allow you to take the balloon further. So you can see here Corsair at the site of the CTO. We are bringing in a rotawire. Rotawire does make an easy pass, and you can see on the right of your screen rotawire lying into the distality. And then the things were quite easy. We made sure that the rotawire is in good position. You could have injected from the opposite side and made sure but we didn't do that. And this is another case where a similar technique was used. You bring either, you cross the wire, but the balloon was not going. And under these settings, you bring in a microcatheter or a corsair, let it stay as much close to the total occlusion, and through this you push your rotor wire, and then you do a burr. So this was on LED in some other case, and we had this kind of experience which we keep doing again and again. Balloon not crossing, wire has crossed, we resort to all these techniques, and you can see the 1.5 burr making good progress through the lesion. So you have to be 100% sure that you are in the lumen when you are using rotablator on these kind of so rota crossed, and you can now see the distal vessel. Things beyond this, of course, are very easy, and you can bring in a bigger balloon and finally stent. So this turns out to be a very big vessel. So two good-sized and long stents, and this is the final result in which you end into a CTO. So this was actually a double CTO, fairly high syntax score, as you can call it. I hate to look at David when I'm showing this kind of scene, but I mean, no harm done. I mean, you're able to achieve both the CTOs very effectively. This gentleman was told clearly that we can definitely get the circumflex very high probability, something like 90–95%, and we'll correct the LAT if it was significant. RCA, he was willing to stay on medical treatment if we had failed. So this is how we manage two different CTOs, different techniques. And the way we had to take steps for the right, where wire had gone, but balloon was not going. I think very occasionally you run into these kind of situations, and these could be some of the steps in which we can address these lesions.